everyone. This is Dr. Pruett. Today we're going to take the opportunity towards the end of the year to kind of review trends and things that we've seen over the last year and kind of take a step and look forward to what's coming next year from the EMS division. First thing I want to start off with is just letting you guys know what a great job you're doing. I'm so proud of everyone, and I don't know that you hear that enough. I want you to hear it from me that you're doing a fantastic job, and I want you to keep up the great work, and I'm really proud of you. I don't know how many of you know this, but over the last year, I've traveled to several different conferences around the country. Starting last January, I was at the Association of EMS Physicians and got to talk a little bit about our behavioral health programs at Eagles in Dallas with a bunch of medical directors and representatives from the biggest EMS agencies in the country. We got to talk about our ultrasound and some of our cardiac arrest data, which generated a lot of discussion. And then this fall, I've traveled to Nashville with IAFF talking again about ultrasound. And then most recently got back from EMS World in New Orleans doing some clinical education work there. But everywhere we go around the country, it's always very clear that we're doing a great job. We're leading the way. And I want you to know that because all of the great things I get to brag about come from the hard work that you're doing out in the field. To start off with, we've got an incredibly sophisticated system. When I talk to people from other cities around the country, very few of them have automated CPR devices. I think we're the only one in the country I know about that's using the ultrasound right now in the pre-hospital setting that isn't a flight environment. And then the fact that we just did the field cannulation for ECMO, the first in the Western Hemisphere, is also a really big deal. So we're doing a really great job. And we have a lot to be proud of here in terms of our EMS system. Just in the last year, we've rolled out a lot of new equipment as well. We've got the new CPAP devices to make our respiratory complaints a little bit easier to manage. We're rolling out a ventilator, which should be hitting the streets pretty soon. And with some very important feedback from the field, we've added the half-size pediatric supraglottic airways to our arsenal as well to make pediatric respiratory arrests more manageable. So keep those suggestions coming. Let us know how things are going. It's a pretty adaptive and responsive environment right now, and happy to make your jobs easier if we can. Over the last year, our training is really focused on respiratory emergencies and on trauma. Just a quick recap, we do have those new CPAP devices, should make it a little bit easier, but for your respiratory distress patients, remember your 5 things. If you have a COPD, consider inline duoneb. Give your steroids and MAG if you're moving to CPAP. Remember, any shortness of breath complaint needs a 12 lead. And then your nuclear option if you have impending respiratory failure is your intramuscular epi. Remember that it's okay to stay and stabilize these patients on scene and treat their underlying problem. You're doing the exact same interventions that would be happening at the hospital, and it's better for these patients if you aggressively treat their hypoxia and their distress early. In terms of our trauma training, we've really been emphasizing this over the last year as well. You guys are doing a fantastic job with the trauma arrest protocol, working those on scene, doing the chest decompression, not having to call an NSEP anymore, and you're leading the way and really pushing the hospital towards understanding the latest developments in trauma by not doing compressions and trauma arrest. I know sometimes that's a little bit awkward for you guys when you get there and they do it, but you're really pushing the hospital to do the right thing there. A lot of our trauma training has emphasized good basic life support skills, so preventing hypoxia and head injuries is a very important thing that we do, and remembering that that's a basic skill to manage that airway, probably one of the most important things that we do on every call. Also regarding tourniquets, stopping bleeding early, also a basic skill, very important and absolutely saves lives. Pelvic binders, we're doing better with considering these in our major traumas. And then we're starting to do better about recognizing tension physiology and documenting when those patients have hypoxia, hypotension, shortness of breath with the correct mechanism. We are being aggressive in our treatment of that and documenting it correctly. So I'm really proud of you with your efforts in trauma over the last year, and hopefully we'll just get better and better with that. A quick reminder as we're looking back on the year, just continue to focus on those fundamentals. I know we have a lot of fantastic equipment that's rolling out, and it's pretty exciting, but fundamentals are always the most important. So remember that vital signs are vital. If you're transporting a patient in that's critically ill, I like to see a couple of sets of vital signs, not just one set. Continue to monitor those because they do change and they do help dictate your treatment. I want everybody to continue to be aggressive managing airways, realizing that hypoxia and lack of oxygen to the vital organs can cause irreversible damage. So this is especially important in our overdose patients. Get somebody on their airway right away. Don't waste time getting the Narcan out, but help them breathe until you can get the medication on board. Be aggressive if you see a hypoxic patient, realizing that their heart or their lungs or their brain are in danger of irreversible damage. Just a quick note about basic airway management for those of you that are up at the airway and managing the BVM. The best technique that you can possibly do is the 2 thumbs down. That gives you a better seal over the face. Ideally, you'll have 2 people there, one to help seal the mask over the face, and then the second person to help squeeze the bag and provide the oxygen. If you need to, don't forget your airway adjuncts for the oropharyngeal airway or the nasopharyngeal airway. Make sure when you're pushing that mask onto the face that you're not smashing the face, but you're lifting the jaw into the mask. And then always use your capnography to monitor your effectiveness of your respirations. It's important as we're given medications to always remember to do your cross checks. This goes for every patient, every medicine, and every level of provider. I'm glad to see us out there treating our patients, whether it's treating pain or treating seizures or whatever medications we're given. We're doing a great job. Just make sure that you are doing the best thing for your patient and keeping them safe and double checking all those medications and doses every time you give them. We rolled out a new app over the last year. It should have all your references in there that you need for any question that might come up in regards to treatments or guidelines or drug doses or references. Please continue to use that. If you haven't downloaded it yet, please get with your officers or with your 7-8 to have access to that. It's a really handy reference. And as you use it, please don't hesitate to give feedback up through your chain of command. If you see something that you have a question about or have ideas of ways to make it better, please funnel that up. We're always interested to hear how it's working out in the field. A quick reminder with your documentation, as we're trying really hard to highlight all of the great things we're doing as a system, it's a lot easier from a management standpoint to find out exactly what we're doing. If you use the drop-down menus for any procedures or interventions that you're performing on the scene, it makes it easier to search the large volume of charts for certain criteria and to pull data about our outcomes. So please, please, please use those drop downs for any procedures and interventions that you do. One other important thing as we're trying to gather data about what's going on in our city and in our system is to use the provider impressions. That really helps us monitor trends. One of the important trends that we've been looking at lately is opiate overdose deaths, and those are very difficult to track because they can come in as multiple different codings, whether it's a 23, 32, 26, sometimes even 9 echoes. It's hard to pull that without having one central place to go. And if it's coded as a provider primary impression of opiate overdose, that makes it easier for us to pull the numbers. Another thing I would just like to emphasize, and we're doing a good job with this, but realize that we're monitoring these numbers, is to remind you just to give aspirin for any chest pain complaint as long as there's no contraindication. It really is the only thing we do in chest pain patients that helps improve their mortality. Another quick reminder, this is new this year and is very, very important for our patients that are having strokes. As you do go to those stroke calls or start to recognize strokes, once you do your Cincinnati stroke scale and realize that it's positive, please move on to the Lamb scale to look for large vessel occlusions. These are the types of strokes where the patients might be eligible to go in and actually have the clot removed from their brain by a thrombectomy. So your Cincinnati positive patients, move on to the Lambs. If their Lamb score is greater than 4, this counts as a large vessel occlusion, and they need to go to a thrombectomy-capable hospital. Right now, the 2 hospitals in our systems that can do this are UNM and Lovelace. And remember, this is a very important intervention for these patients. Make sure you're discussing with the family about the destination in case it's changing where they would prefer to go. Just help explain that these are the only 2 hospitals that have the absolute best treatment for this patient right now. We're doing a fantastic job with ECMO, running our inclusion and exclusion criteria on every cardiac arrest. It's important to still consider this as we're starting to transport patients to the hospital if they're close enough, or calling the mobile ECMO unit to the scene. As this becomes more common, please remember to document these either transports or responses by ECMO 1. This helps us keep track of our numbers. There is a pull down for the different types of ECMO responses. Also, please remember to continue getting 12 leads for any chest pain. We're doing a great job with this. Every chest pain patient is getting 12 lead. I'd like to see us expand and do even more for patients that are experiencing syncope, shortness of breath, dizziness, altered mental status. A lot of these older patients can come in with very vague complaints that could very well be cardiac in origin, and I'd like to see us continue to get more 12 leads and interpret them correctly. Another relatively new thing in our system over the last year has been the early radio alerts. What trauma is not new, but for elvo strokes, STEMIs, ECMO alerts now, and also sepsis alerts, it really helps the hospital if you can give them advance notification that you're coming with a patient that's going to need specialized care to meet them in the emergency department. This is especially important for strokes, for STEMIs, and for ECMO, as each of these will require interventionalists to come to the ED, and time is of the essence for these life-threatening emergencies. So getting them to the hospital or giving the hospital warning as soon as you possibly can from the scene will just help that patient's outcome be even better. Quick note, as I've been reviewing charts, I see that we're still giving a fair amount of Narcan in cardiac arrest, as well as occasionally giving D10. I just wanted to remind everybody and maybe explain the thought process behind this, is that if you have a patient who's already in cardiac arrest, which means that they're not breathing on their own and their heart has actually stopped beating, Narcan, it's a little bit too late to use Narcan. It's not going to restart the heart. Same thing with D10. What that patient needs is really good CPR and epinephrine. And then maybe if you do get the heart to restart, at that point, after you have ROSC, you can consider giving Narcan and you can consider giving D10, but I wouldn't give them until you do get a ROSC, realizing that they don't help in cardiac arrest, they don't restart the heart, and you need to focus on the other interventions that we know that do help. So as we're looking at moving forward to next year, what kind of things are on the horizon? We have the ventilator that's rolling out. We'll do some training on this. Why I'm excited about this is because it's been proven to improve cardiac arrest outcomes. We've already got it on the ECMO 1, but we can use it on other cardiac arrests as well to help regulate our ventilations and our tidal volumes. Our training over the next year is mostly going to focus on cardiac emergencies and getting really good at 12-lead interpretation. We're going to do a large amount of training with EKG interpretation and recognizing and treating cardiac emergencies. And then we're also going to focus on pediatrics. I feel like this is an area where nobody's ever super comfortable, and I would like to see us get more comfortable here. And that will be a big focus for our training over the next year. As a division, when we meet every month, these are the metrics that we're looking at. I think you can see the charts and graphs when you open Image Trend to see how we're doing. And we're doing actually a really great job with all of these. We're giving aspirin for chest pain, which we mentioned before is the only thing that helps with mortality as long as there's no contraindication to it. We're doing a great job getting EKGs for chest pain. I'd just like to see us do that for more common complaints that could be cardiac in origin. We're doing an okay job with pain management. I think there's room to improve here, especially with non-narcotic pain options. Strokes, again, with the new elvos, I'd like to see us document those Cincinnati's and LAM scores a little bit better and get these patients to the correct destination quickly to get them the intervention that they need. And then we're keeping a close eye on the use of restraints as well, whether that's physical or chemical restraints for our agitated patients, and we're doing a really strong job there and a great job with that. Overall, I'm super proud of everybody. Keep up the good work. If you have questions, please continue to ask. Funnel those up through your chain of command or through the 7-8. We're always happy to talk about medical things or questions as they arise. And if you do have any questions, please bring them to your 7-8. Thank you.